Good morning, and thank you for joining me today. My name is Maggie. I'm a master's candidate here at Eastern New Mexico University. A little about me: my primary perspectives are from acute care and teaching hospitals, but the topics we discuss today can definitely apply to other care settings as well. I know that our audience is comprised of working, experienced nurses, so again, I do thank you for finding the time to join. Some of you may already be in nurse educator or leader roles in your organizations. Or maybe you're like me and never have held a role beyond staff nurse. In either case, hopefully we will all have a few good takeaways today. Let's get started. Today's session is called Putting Theory into Practice, using Dr. Benner's novice to expert theory to guide the first year of nursing practice. Objectives for today: by the end of the session, learners will be able to appraise how their organization's onboarding processes address challenges for first-year nurses, identify an action or actions to improve their organization's first-year nurse experiences, and lastly, apply Dr. Benner's framework when planning for future first-year nurse onboardings to our organizations. Why should we talk about this? I'd like to take a few minutes just to share a few of the research findings I collected that personally I found sobering. And I imagine your organizations are dealing with these issues too. One study by the National Council of State Boards of Nursing recently found that 25% of current working nurses intend to leave the workforce entirely by 2027, especially among new grads. This is such a shocking number. Nurse turnover amongst the new grad population has long been a serious issue. I don't remember it being this high. Additionally, Dr. Benner mentioned in her article I shared with you for the pre-reading that nursing in acute care settings has become so complex that it's no longer possible to standardize, make routine, or delegate out much of what the nurse does. Increasing acuity, decreasing length of stay, and proliferation of health technology has only increased the need for experienced nurses. And Dr. Benner wrote this back in 1982. So much has changed. Many organizations are rightfully concerned about their costs. Mine is too. I want to share with you a study from 2005 in which one hospital had 3 specialty service lines with so much nurse turnover that just those 3 service lines spent on average $6 million in a year on turnover. I really cringe when I think about that number in comparison to the number of nurses and nursing assistants who need and deserve a raise or just better healthcare coverage. Another study found that there are more preventable errors during a new staff nurse's first year of practice than at any other time in their careers. So let's move on and discuss things like improving direct patient care and clinical outcomes, definitely a big focus right now across the continuum of care. We need to pay attention to reducing the cost of recruitment and retainment for facilities. There's a much smaller applicant pool to choose from these days. Taking good care of our staff by reducing trauma, moral distress, and burnout. Lastly, high rates of nurse turnover have serious economic and non-economic implications for all healthcare systems. Dr. Benner noted how recognition, reward, and retention of the experienced nurse in positions of direct clinical practice is crucial to improving healthcare quality. Next up is a brief reflection exercise. If participating in a reflection on your first year of nursing would trigger any emotional difficulty related to past traumatic events, please feel free to sit it out. If you do feel you can participate, pause the session, take just a couple minutes to think about your first year of practice, and if you would like, use one of these question prompts. What was it like? What supports were you offered during your transition from student to professional? Did you have any negative experiences that stayed with you? Did your employer have any formal processes or programs in place to support first-year grads? All right, hopefully that got us all thinking. In order to be respectful of your time today, let's keep moving forward. I'll share a reflection from my first year of nursing, which was honestly one of the hardest years of my life. My first job was in an East Coast teaching hospital. My unit was a little unique in that we were high acuity med surge, but we also had an embedded small surgical ICU step down unit. I did not get a benefit from a formal transition to practice program, but I did have 12 weeks. Needless to say, my unit was eager to get me off orientation and start filling holes in the schedule. Night shift contributed to my transition shock. Unfortunately, I oriented with so many different staff nurses that I lost count. And my unit lacked a deep bench of experienced, strong nurses that I really could orient with. I had an interaction with a nurse who I will call Beth. That is not her real name. Beth absolutely hammered me during one patient transfer report. I was in the step down unit, she was on the floor. She questioned every action I took, made me feel lesser than dirt. Maybe an hour later, Nurse Beth flew back into the room, screaming at me about a patient's bowels. I kid you not, it was about bowels in front of my preceptor and all the other patients. Unfortunately, my preceptor didn't stick up for me in that moment. We never really addressed it. That said, I'm sure that a lot of you listening today have had worse experiences than me. That said, the incident negatively impacted my confidence and my progress for at least a year, if not more. And my unit would have really benefited from a transition to practice program or any sort of program modeled on Dr. Benner's work. What is the novice to expert theory? How can it help? Dr. Benner works at UCSF. She took the Dreyfus model of skill acquisition, which describes how skill acquisition is incremental, and she modified it to apply to how nurses achieve their educational milestones and psychomotor skills. It is a widely respected and used theory. Some key points are that it helps name and shape the transition that all new grads inevitably face. It also provides important recognition that healthcare systems need to anticipate new grad needs in a different way. Dr. Benner's theory expands into 5 levels of proficiency, and here they are. Novice nurses can be described as those in school nursing students. They have no experience, no context with which to see professional care. For advanced beginners, they have completed nursing school and really are our target population for today's session, new grads. They have minimal experience, but they can begin to see how some of their prior experiences can apply, giving context for the current nursing care that they're providing. To get to the competency level, nurses typically need 2 to 3 years experience. These nurses can start seeing the forest for the trees. They can start seeing the long-range implications of what they're doing at the bedside. I want to pause for a moment and share that on nights, my current unit only has 5 nurses who have more than 3 years of experience. That's concerning. And moving on to proficient level, these are the nurses who are beyond that 3 years experience. They clearly see both forest and trees. They have a deep understanding of nursing interventions and the impact that they have on outcomes. They know in a very clear way how, for example, teaching a patient to use the incentive spirometer can prevent a readmission for pneumonia. Now to the expert level of proficiency, nurses typically have 5 years or more experience. They are so highly skilled that they are resources for not only the unit, but the entire organization. They have enviable amounts of intuition about their nursing interventions. And thinking back to the start of this session, proficient and expert nurses are the ones organizations really need to cultivate and retain if we want to achieve improved patient care outcomes and reduce costs. Let's discuss transition shock from classroom to bedside. I remember my transition being rough. I didn't have a mentor, just fellow new grads to commiserate with. Dr. Benner's theory highlights how this shock that happens in the first weeks of a new grad working has to be acknowledged and honored by our healthcare employers. Adapting to new workplace cultures and vast expectations is hard. Charting correctly during night shift is hard. As an example, hopefully, healthcare leaders can try to view novice or advanced beginner nurse stats from the EHRs with compassion and instead of, maybe discipline. We don't want to set people up for failure. It's important to highlight how novice to expert theory helps organizations create effective plans to keep the nurses they already have while also effectively recruit promising new staff into the organization. So, who are the Benner stage advanced beginners? Well, new grads. They do add value to healthcare systems. They have fresh energy and knowledge of evidence based practice. Hopefully, they should not be met with an extra heavy assignment. As a preceptor, I know I have learned so much from the nurses I've oriented. They can speak to the why behind the care we're providing. They benefit from formal transition to practice programs instead of the old saying, see one, do one, teach one. I wish this saying would just go away because no one could be expected to do a clinical task properly or safely with a good outcome after watching just one. No one should be teaching a skill after doing it once either. Transition to practice programs incorporate the Benner concept of incremental skill acquisition while providing new grads with a supportive work environment. Let's move on to a discussion about what the first year nurse needs. They need consistent assignments with one or two primary preceptors who are willing and able to participate. Preceptors should know their preceptees and their strengths and their weaknesses. Maybe they really are a novice instead of advanced beginner, and that's okay. First year nurses really need clear expectations and a logical timeline along which they can track their own progress. They need psychological safety to ask questions, admit and correct mistakes, and build their professional integrity. We want staff to feel safe to speak up. It would be ideal if we could have units that are adequately staffed with assistive personnel, not to mention the facility as a whole. With good staffing, this could help avoid float assignments for at least the first year. We can try to do what we can to make sure new nurses have the help they need during shift. CNA, health tech, charge. I think one of the biggest things that helps new grads is a sense of teamwork and belonging. We should ask ourselves, do we treat each other with respect? Do we try to get to know each other? And at a bare minimum, can we ask ourselves, do we help each other? How can this theory be applied in our workplaces? Here are three perspectives: colleague, manager, and facility leader. First, we'll start with colleague, which is kind of my perspective. Applying the novice to expert theory could start as simple as planning out patient care assignments with skill level in mind. Avoiding high acuity and high patient ratios is very helpful. I think we can all attest to that when we were new grads. Also, could we try to avoid high skill patients like fresh laryngectomies or new start chemo? If you're in the charge nurse role, offering help and positive reinforcement is key. What tasks could we take off the new grad's plate? It's worth noting that some expert nurses may not be expert teachers. My reflection exercise with Nurse Beth is a perfect example. I've learned that there's a lot of value in praising in public but correcting in private. It goes a long way for psychological safety. No one wants to constantly be criticized, and that doesn't set up nurses for success. Additionally, could the unit form a practice-based council? Nurses who have a sense of control over their practice and work area are more engaged and likely to stay. Lastly, this is an inspirational quote that I use on a daily basis when I think about how to make my unit better. Be the nurse you want to work with. Wish I had thought of that one. And here are some ways that Dr. Benner's theory could be applied by managers within an organization. Nurse managers should take actions to ensure their units have a good bench, to use a sports metaphor, of qualified preceptors who have received training on how to teach effectively. It's important to note that there's a significant shortage of expert clinical preceptors and also at times inconsistency in their training. Both of these things I know are tough for just a single manager alone to address, but hopefully managers can advocate for staffing levels that allow their preceptors to attend trainings, have one-on-one time with their preceptees. Nurse managers could complete annual performance evaluations with the nurse's Benner stage in mind. They could consider participating or creating even their own formal transition to practice program, or other options like nurse residencies or dedicated education units. They could be a host for a DEU. Managers can contribute to a positive unit culture where we're celebrating achievements instead of only hearing about errors. How can we make sure that we have meaningful recognition that's shared widely? I'd like to share a good example from my current unit. Anytime a nurse is nominated for a Clinical Excellence Award or gets a nice letter, the nurse manager reads it aloud at Safety Huddle for everyone to hear. And what a great way to start the shift. I really appreciate that. Lastly, managers should also conduct exit interviews to determine reasons why a nurse resigned and what could be done differently in the future. Turning now to healthcare organization leaders, they should take Dr. Benner's advice that to achieve patient care excellence, we have to have expert staff. Systems can't experience such brain drain that whole service lines are destabilized or even procedures canceled. It's wild to think about how the most senior nurse on some units has only 10 years experience in. System leaders can examine why this might be. Direct care nurse roles are incredibly taxing on the body and mind. Patients can be assaultive. We need to take care of expert staff, cultivate them, and keep them committed to the organization. We all benefit from their skills, intuition, and expertise. Organization leaders could see how a framework like Novice to Expert improves the new grad nurse's transition to professional practice. Novice to Expert theory, transition programs, ongoing education, they all save money in the long run. Could the organization consider offering increased pay, expanding clinical ladders of advancement, other recognition to their experts? Motivating preceptors is key. It's important to stress that education does not stop at graduation. Healthcare organization leaders could also connect with local academic nursing programs to create an academic practice partnership. It creates an employment pipeline while also offering preceptors clinical instructor titles at the school. We also want to make sure that all clinical nurses have regular access to master's level prepared educators across all clinical areas. We could encourage staff to utilize this valuable resource. Lifelong learning is a critical attribute of the expert nurse. Like with all things, there are definitely barriers to implementing some of these ideas. As a nation, we have a well-known lack of reliable funding for healthcare. There are not enough resources for dedicated continuing education and one-on-one time with preceptors during nursing shifts. Nurses need time away from the bedside to reflect, build skills, go over what went right, go over what went wrong, and celebrate achievements. I'm sure none of this is surprising to this audience. To put it simply, healthcare in America is in crisis mode. There might be a lack of buy-in from leaders at some organizations too. I feel like leaders are really stressed. They are being asked to do more with less amid evaporating healthcare dollars. Pushback from payers and regulators certainly doesn't help. It can be hard to field more requests for FTEs with all of these challenges. There's also obviously, upfront economic and opportunity costs in building out transition to practice programs. And just to put it bluntly, skeleton level of staffing makes it difficult to initiate new programs and makes it difficult to deal with shift skill mixes where there may not be a person on shift who's experienced enough and qualified to precept. One thing that Dr. Benner very aptly noted back in 1982 is that we are now seeing levels of patient acuity that I've never seen in my entire career. It can feel impossible to find time to attend trainings or have these long transitional practice programs. It's really tempting to pull a nurse from orientation early and get them into the schedule to be productive. I know we as experienced nurses have all been put into those difficult situations when we've been in charge and trying to staff the unit. It's worth assessing whether or not your facility's staffing grids and staffing plans actually reflect the acuity of today, not the acuity of 10 years ago. The current organizational culture seems to place a higher value on physicians' residency and training, but not on nurses. Physicians get dedicated time during their residency hours for training, time that's partially paid with Medicare dollars. And could nurses receive the same? Key takeaways from today's session: can we work toward reasonable patient care expectations based on the new grad nurse's Benner stage? Preceptors need dedicated time away from patient care to facilitate learning and ensure success. Healthcare organizations have to recognize their role in recruitment, training, and retaining the next generation of nurse experts. Doing so really will impact our bottom lines. On a larger sort of scale, we all need to advocate at all levels for investment in nursing education beyond traditional academic settings. Healthcare systems across the country are being pushed to the brink. Nurses are leaving in droves. Let's work together to change that. We started a reflection. Let's close with one more. We heard all of Dr. Benner's great advice. Let's pause and take 2 minutes to think about the first example you came up with at the beginning of the session. Would any of what we've talked about today change your first year of professional nursing? Do you wish your preceptors or manager had attended today? Let's consider what actions we can take today to hold space for the Benner expert levels that we need tomorrow. I do really hope that you will respond to this brief survey to give me some feedback about the session today. Please feel free to contact me with questions or concerns. I do appreciate that feedback. It'll help improve future teaching. And here are some references that I hope might be helpful to you as you continue progressing in your careers. I want to thank you for your time and your attention today. It's valuable, I know, so hopefully today has provided a refresher on theory and practice combined with some actionable items for the future. Thanks again so much for your time.